Good morning, everyone. Today's topic is treatment guidelines for hypertension. Why treat hypertension? To decrease cerebrovascular accidents, which are 35 to 40%, coronary events, 20 to 25%, heart failure, 50%, progression of renal disease, progression of severe hypertension, all cause mortality. Factors to consider in treating hypertension: repeat readings, risk of secondary causes, estimate cardiovascular risk status, comorbid conditions, lifestyle changes, drugs. Systolic and diastolic values used in the classification of hypertension. Blood pressure category: normal, less than 120 mmHg systolic, and less than 80 mmHg diastolic. Elevated 120 to 129 and less than 80. High blood pressure hypertension stage 1, 130 to 139 or 80 to 89. High blood pressure is hypertension stage 2, 140 or higher or 90 or higher. Hypertensive crisis higher than 180 and higher than 120. Classifications and management of BP for adults: normal less than 120 and less than 80. Lifestyle changes encouraged. Initial drug therapy without compelling indication, none. Compelling indication, none. Pre-hypertension, 120 by 139 or 80 to 89. Lifestyle changes, yes. And initial drug therapy, no antihypertensive drug indicated. And compelling indications, then drugs indicated. Stage 1 hypertension, 140 to 159 or 90 to 99. Lifestyle changes, yes. Or initial drug therapy without compelling indications, we use thyroid type diuretics for most. May consider ACE inhibitors, angiotensin receptor blockers, beta blockers, calcium channel blockers, or combination. If compelling indications, then use other antihypertensive drugs, diuretics, ACE inhibitors, angiotensin receptor blockers, beta blockers, calcium channel blockers as needed. Stage 2 hypertension, if systolic blood pressure greater than 160 and diastolic greater than or equal to 100. Lifestyle changes, yes. Initial drug therapy without compelling indications. Two drug combination, usually thyroid and ACE inhibitors or angiotensin receptor blockers or beta blocker or calcium channel blocker. If compelling indications, same other antihypertensive drugs, diuretics, ACE inhibitors, angiotensin receptor blockers, beta blockers, calcium channel blockers as needed. Non-pharmacological treatment, lifestyle modification, control of obesity, BMI 20 to 25 kg per meter square. Dash diet, restrict salt in the diet, less than equal to 6 gram NaCl. Reduce intake of fat and saturated fat. Increase consumption of diet rich in fruit and vegetables, greater than equal to 5 portions of fresh fruit per day. Reduce alcohol consumption to less than 3 units per day for men, less than 2 units per day for women. Avoid cigarette smoking and physical exercise. Pharmacological treatment include ACE inhibitors and ACE inhibitors. We use Ramipril 5 to 10 mg daily, captopril, angiotensin receptor blockers, for example, telmisartan 40 mg daily, losartan 50 to 100 mg daily. Calcium channel blockers, nifedipine, verapamil, amlodipine. Diuretics, furosemide, chlorothiazide. Beta blockers, atenolol and propranolol. Recommendation in hypertension management. For younger patient less than 55 years of age and older patient greater than 55 years of age, we use treatment plan A, which includes ACE inhibitors or angiotensin receptor blockers. Choose a low-cost angiotensin receptor blocker. For older patient, we use treatment plan C or D, which includes calcium channel blocker, but consider a thiazide-like diuretic if a calcium channel blocker is not tolerated or the individual has edema, evidence of heart failure, or high risk of heart failure. And treatment plan D, thiazide-type diuretics, consider a low dose of spironolactone or higher doses of the thiazide-like diuretic. Step 2, for younger patient, plan A plus C, and for older patient, plan A plus D. Step 3, for both patients, we use plan A plus C plus D. And step 4, resistant hypertension, A plus C plus D, Plus, consider further diuretic or alpha or beta blocker. No hypertensive urgencies and emergencies. Hypertensive emergencies require immediate blood pressure reduction, not necessarily to normal range, to prevent or limit target organ damage by IV intravenous drugs. Hypertensive urgencies, severe elevation in blood pressure greater than 180 by 120 mm Hg without symptoms or signs of acute target organ involvement. Adequate treatment of these conditions, a BP lowering within 24 hours by administration of oral drugs. Require reduction of blood pressure within a few hours. References from Harrison's Principles of Internal Medicine, the Morsley Prescribing Guidelines in Psychiatry, 13th edition. Thank you. Yes.
Morning to all. Good morning to all. Today topic is diabetes in psychiatry by Dr. Vivek Kumar MBBS intern, moderated by Dr. Sarthak Bhandari. Diabetes mellitus is a chronic metabolic disorder characterized by high blood glucose level resulting from defect in insulin secretion, insulin action, or both. It affects millions of people worldwide and is a significant global health risk. Types of diabetes mellitus: type 1 diabetes, type 2 diabetes. Type 1 autoimmune condition where the body immune system attack and destroy insulin producing beta cell in the pancreas. Requires lifelong insulin therapy for survival. Typically develop in childhood or early adulthood. Type 2 diabetes. Most common form accounting for 90 to 95% of all diabetes cases. Insulin resistance and impaired insulin secretion are the key features. Linked to lifestyle factors like obesity, sedentary behavior, and unhealthy diet. Symptoms: frequent urination, excessive thirst, unexplained weight loss, fatigue and weakness, blurred vision, slow healing wounds or infection, tingling or numbness in hands or feet. Diabetes and mental health are closely interlinked, and this presentation explores the complex relationship between diabetes and psychiatric disorders. The bidirectional nature of this relationship means that diabetes can affect mental health and psychiatric condition can impact diabetes immunity. Prevalence of diabetes in psychiatric patients. Diabetes prevalence is higher among individuals with certain psychiatric disorders compared to the general population. Common psychiatric conditions like depression, anxiety, bipolar disorder, and schizophrenia have an increased prevalence of diabetes. Patients with severe mental illness are at a high risk of developing diabetes due to various factors, including lifestyle choices, medication side effects, and biological mechanisms. Risk factor for diabetes in psychiatric patients. Unhealthy lifestyle habits, such as poor diet and lack of physical activity, are significant risk factors for diabetes in psychiatric patients. Certain antipsychotic medication can lead to weight gain and insulin resistance, contributing to diabetes development. Stress and emotional factor may lead to unhealthy coping mechanism, further increasing the risk of diabetes in vulnerable populations. Impact of diabetes on mental health. Diabetes can have a profound impact on mental health, leading to increased stress, anxiety, and depression. The burden of managing diabetes can create emotional distress, resulting in decreased quality of life and poor mental well-being. The fear of complication and the chronic nature of diabetes can lead to feeling of hopelessness, helplessness, exacerbating existing psychiatric conditions. Impact of psychiatric disorder on diabetes management. Patient with psychiatric condition may struggle with self-care and adhering to diabetes management plans. Depression and anxiety can hinder motivation and lead to neglecting blood glucose monitoring, medication adherence, and lifestyle changes. Psychiatric symptoms may interfere with cognitive functioning and decision making, affecting diabetes management negatively. Screening and early intervention. Routine screening for diabetes risk factor in psychiatric patient is critical for early detection. Identification high risk patient allow for timely intervention to prevent or manage diabetes effectively. Lifestyle intervention, education, and support groups can empower patients to take charge of their health. Medication management. Psychiatrists must carefully consider the choice of antipsychotic medication, favoring those with lower metabolic side effects. Regular monitoring of metabolic parameters and shift intervention when necessary are essential to minimize the impact on diabetes. Psychological support and education. Providing psychosocial support and education to patients can improve their mental well-being and diabetes self-management. Addressing emotional barriers and improving coping skills can enhance diabetes-related outcomes. Peer support group can create a sense of community and reduce isolation. Lifestyle modification. Encouraging a healthy lifestyle, including a balanced diet and regular physical activity, is a crucial for diabetes management. Collaboration between nutritionists and mental health professionals can promote positive behavioral changes. टाइप 1 में उसमें जो ऑटोइम्यून सिस्टम एक्टिवेट होता है और जो बीटा सेल होते हैं पेनक्रियास उनको डिस्ट्रॉय कर देते हैं टाइप 2 में जो इंसुलिन करे तो वो भी लाइपोग्लाइसिन मेटफॉर्मिन वगैरह टाइप 2 में इंसुलिन रेजिस्टेंस है और लाइपोग्लाइसिन